Once again, my name is Dr. Pandya. I work over at UCSF and here at Children's, and I'll be talking about cartilage injury in the young athlete. There's my email address and my Twitter handle. Feel free to contact me at any time. So really the goals of this talk are, number one, we're going to talk about epidemiology. Number two, talk about some basics about cartilage, particularly the biology. We'll talk about mechanisms of injury, things you want to look for in the history and exam, X-ray and MRI findings, treatment conditions, and some things about what's coming in the future. Now, I think one of the things we have to, kind of really realize when
Your attention, please. There will be a test of the group alert pagers. If your unit does not respond to the test, please notify the operator. Your attention, please.
Every time.
There will be a test of the group alert pagers. If your unit does not respond to the test, please notify the operator. Thank you.
Sorry about that. We're in the hospital right now, so we're seeing a drastic increase in the types of injuries we're seeing in kids, particularly cartilage injuries that were simply just used to be adult injuries. So once again, we're having 14-year-old patients who come in needing meniscus transplants, where they need an artificial meniscus put in because they've had so much cartilage injury. We also have kids who damage their articular cartilage, and we'll talk about the difference between the various types of cartilage. You need to have artificial cartilage put in to basically help their knee regrow and to be active. So once again, these were injuries we weren't seeing in kids 10, 15 years ago. Now they're getting these injuries that we used to see in 20, 30, and 40-year-old patients. And I think a lot of this has to do with some of the trend we're seeing in youth athletics. And this is a great website I encourage you all to go to. It's called the Stop Sports Injuries website. You just type in Stop Sports Injuries into Google. And it has great information for any kind of sports condition you're looking for in kids. One of the great statistics they have on this website is that 50% of all pediatric athletes will suffer at least one significant injury a year. And that's an injury that will potentially require a trip to the emergency room, a trip to an orthopedic surgeon. So once again, the trend of kids simply just having sprains and bumps and bruises is now becoming more serious with these severe ligament and cartilage injuries. And a lot of this has to do with the fact of where our kids are playing sports these days. And although 5.5 million children playing in-school sports seems like a large number, there are actually almost 6 times more kids playing sports out of school. And as kids start playing sports out of school and are doing it in a more professional, organized fashion, that's where they're getting more professional, organized, athletic-type injuries to the cartilage and the ligaments. This has also occurred at the same time that physical education has dropped a lot in school. So once again, getting core principles of stretching, running, playing multiple different sports, they're basically just all going to specializing in one sport. And as a result, we get one group of kids who are super specialized, super elite, and are getting these adult injuries at a young age. And then we have this other group of kids who just don't have access to sport specialization with the clubs and all the money that's involved, and they don't have access to being able to stay healthy and active. And those are the ones who are then more susceptible to diabetes, to heart disease, et cetera, when they're older. Now, the problem with this elite group is that a lot of them are playing one sport year-round and basically just playing baseball, just playing soccer, and that's where a lot of these cartilage injuries can take place. So the best prevention is not even getting these injuries in the first place and being a multi-sport athlete who plays multiple sports and doesn't push their body to the limit. I think a lot of this pushing comes from this 10,000-hour rule, where basically there was this person named Erickson who said that in order to become an expert at anything, and he used music as an example, you need to do it for 10,000 hours. Now, this study has basically been misproven in multiple different ways, but once again, people took this and felt that, look, the only way I'm going to get good at something is to just practice it all the time, and that actually becomes detrimental, particularly for sports. So the problem is we have these super young kids who are specializing in sports and positions at an earlier age. This leads to particularly this really young age group having a significant amount of sports injuries. We see 3.5 million children having these very significant injuries who are under 14, a group that normally wouldn't see an orthopedic surgeon for a sports injury in the past. And this is a lot has to do with the fact that they're still growing, they're not taking time to rest, they're not getting trained by the appropriate people, and they continue to play even when they have pain. And as a result, they really don't have outlets for just basic free play, playing in rec leagues, simply because it's a lot of money is involved in this and everything has to be done at a club organized level. So it really is this business of youth sports where I think when I want to think about cartilage injuries, they really go hand in hand, where kids are playing these young sports at younger and younger ages. And you take, for example, this showcase that was held, and they basically promoted as all these college coaches are coming, and even more than you thought would come actually showed up. So kids want to perform because they're being graded on their skills, how fast they can throw, how hard they can kick, rather than how good of a well-rounded athlete they are. And I had this 14-year-old patient one day come into my clinic and said, I'm not going to play playground basketball anymore because it isn't good for my brand. So once again, we have this whole culture of kids feeling that they need to prepare themselves for a professional career in sports rather than simply playing sports for what they believe in for just simply fun reasons. And as a result, they're tearing up their cartilage and having a lot of these injuries that we'll see in a second. So as a result, free play is no longer encouraged, and that's where a lot of these cartilage and ligament injuries root from. And there's a great study proving this. There's a study that was done at Loyola University in Chicago that looked at 1,200 athletes between the ages of 8 and 18 and found that athletes who spend more hours per week playing their sport than their age were 70% more likely to experience severe injury, particularly injury to the cartilage and the ligaments. So if you're going to take anything home from this talk, if you've got kids and they're playing sports, less sports than their hours per week of their age, and that's really going to prevent them from getting the severe injuries and getting the surgeries that I'll talk about for the vast majority of this talk. So one of the things that goes hand in hand with cartilage injuries is ligament injuries, and I think one of the best proxies are ACL injuries, and the ACL is a ligament that basically helps to control the knee and is frequently torn in adult athletes. But what we've seen over the past several years is a number of kids who are getting surgeries tremendously increase. And you can see in this slide over here that kids between 14, 15, 16, and 17 are really young athletes make up the large bulk of the kids who are getting these surgeries done. You can see even 11 and 12-year-olds, kids who would never think would have an ACL injury, are tearing up their cartilage and the ligaments at the same time. You can even see the trend. This is drastically increasing, from the early 90s to where we are now in 2017, and these curves have continued to increase up. Now, a lot of parents will push their kids because they think they can get it to pay for college, with the cost of college now being almost $200,000 for most parents. A lot of these parents think their kids are going to go professional, and they're willing to sacrifice their cartilage for the chance of being professional, but that chance of going professional from being a high school athlete is extremely low. It's 0.0006%. And the chance of even getting a college scholarship is pretty low too. It's about 2%. And even if you get a college scholarship, it's only going to be $11,000. Is it really worth tearing up your cartilage and your ligaments for that? Most likely not, because the amount of money you're going to spend playing that couple seasons of travel ball is going to far exceed that average college athletic scholarship. And the heartbreak that will come from having a severe cartilage injury that could lead to arthritis definitely outweighs the benefits of potentially getting this small money. So once again, we know that playing one sport repetitively, damaging your cartilage, does not lead to an athletic scholarship. What it does lead to is burnout, cartilage injury, social isolation, and poor adult health. So once again, keep your kids active, have them play multiple sports, and if they're good, that'll take care of itself. There's nothing that we can do except injure kids' ligaments and cartilage to help them get to that next level. Now, turning specifically to cartilage. So why is hurting your cartilage bad? And I think if you look on the left over there, that's what a nice normally looks like. On the right is a knee where the cartilage has been destroyed. And that's because arthritis occurs. So when you don't have good, healthy cartilage, arthritis is basically going to pop up, and that's going to lead to decreased function and pain. When a kid has a cartilage injury at age 11, they have lots of years of just normal wear and tear on their joints. They're already setting themselves up to have a very painful joint and less activity when they're older. Now, what exactly is cartilage? So if you look at this diagram over here, you've got bone, and then basically you have cartilage, which is the end, kind of the shiny end of the bone. If you look at a chicken bone or any kind of bone off an animal, you can basically see it's that shiny part on the end of the bone that helps to lubricate the joint. So it's really important to basically keep that healthy because it allows you to move, function, and be very flexible and not have pain when you're doing activities. Okay. And there are various different types of cartilage in the knee, and I'll use the knee as an example for this talk. You have articular cartilage, which is basically the cartilage that is on the end of the bone. That's the shiny cartilage. But then we also have cartilage called the meniscus, which are those two C-shaped structures that are in between the shin bone and the thigh bone up there. And that's also a shock absorber as well too. So there's a lot of different types of cartilage which does different functions, and then ligaments which help to basically protect the cartilage by keeping the knee constrained. So once again, all these things play hand in hand in giving you a good, healthy joint. So there are basically three types of cartilage. There's hyaline cartilage, which basically reduces friction between bones, and that's cartilage found in your joints. And when we say synovial joints, that's the shoulder, the hip, the knee, the ankle, the wrist, etc. Then there's elastic cartilage, and that's a cartilage that's very supportive, but bends very easily. And that's a cartilage that's found in your ear, your epiglottis, or on the tip of your nose. It's very, very flexible, but does give support. And then you have a third type of cartilage called fibrocartilage, and that's the cartilage that prevents bone-to-bone contact. It pads some of the joints, and it's found between areas of your back and in your pelvis. So once again, three different types of cartilage, all which essentially do overall the same thing, but have very different specific roles within the body. Now, the function of cartilage, there's basically 6 things that cartilage does. Number 1, it supports the body. Number 2, provides a framework for ligaments to attach. It also provides an attachment site for muscles. It protects underlying tissues. It helps provide flexibility, and it forms a structural model for growing bone. So it's a very, very important structure, and even a small damage to any of these little functions can definitely cause you to have a lot of arthritis and problems down the road. So it's extremely, extremely important. And really our goal is to prevent cartilage injuries. So on the left, you see an example of a bone, and that shiny substance that you see kind of looking at you on the screen is normal, healthy cartilage. And on the right, you see what a knee looks like when it has very bad arthritis. And you can notice that on that end of the bone, it's not as shiny. And that's what happens when your cartilage wears away. You get bone-on-bone contact, which is painful, and then leads to joint degeneration. So it's something we want to prevent, particularly in our extremely young athletes. Now, the problem with cartilage is it doesn't like to heal. It has a very limited capacity to heal. It has little or no direct blood supply. And the cartilage cell injury results in variable healing, so we can't really predict if it's going to heal or not. And the cartilage that is particularly the worst to heal is the one that's most important, which is articular cartilage. And that's the cartilage that basically is at the end of our bones and our joints. So on the bottom of the screen down there, you see at the top what normal articular cartilage looks like, and then below it what a defective cartilage looks like. Once again, you see the same thing on the right side. You see nice white shiny cartilage and then very defective cartilage there where it's basically been worn down to bone. And that's what arthritis looks like. So once again, we're trying to prevent that from happening. And this is an example in a 7-year-old patient of how bad an injury can get, even in this age group. And the problem, as I mentioned, is that if cartilage doesn't heal, it leads to arthritis. So on that top right picture, this is a picture of a knee during a surgery, and you see at the top, you see kind of what looks like a little ball, that's the femur, and below it's the shin bone, and in between the two structures is what we call the meniscus. That's a nice normal meniscus. And then you look on the right side, what happens to you when the meniscus is very torn. You see a lot of frayed tissue, things that are not as smooth, much more rough, which can be very painful and take people out of commission. The question becomes, how can a young athlete injure their cartilage? Now, we talked about overall how this happens by playing a lot of sports and a single sport at a young age, but there's also specific events that can cause a young athlete to injure their cartilage. Okay? One example I mentioned is an ACL tear. An ACL is a ligament that connects your thigh bone to your shin bone, and when that tears, the cartilage gets damaged because the bones are not moving in a way that they're not supposed to, and cartilage gets affected as a result of that. Another thing that can happen is when your kneecap pops out of place. Once again, your kneecap pops out, the cartilage gets affected, gets worn away, and you can get progressively more arthritis in that area with more of these injuries. And sometimes cartilage can just wear away in a child even with no injury at all, and that's something called an osteochondral lesion, which I'll talk about a little bit later. Some kids are born with this, or it develops over a period of time, but it's when the cartilage in the bone actually becomes weaker, and that leads to degeneration, both of the articular cartilage where it develops from, and then the cartilage below it, because the surface is not smooth anymore. So these are various ways in which kids can basically destroy their cartilage. Now, in terms of how kids will present to my office with a cartilage injury, sometimes they'll have an injury where someone hits their leg. Sometimes they can just be running and pivot and hurt themselves. Sometimes they'll be slowing down. Sometimes they'll be rotating their leg in, rotating out. Sometimes they hear a pop. So there's a lot of different things that can cause it. But the most telling sign for me is when they have a painful swollen knee. And that can either be in the acute setting right after an injury, or sometimes if they have an injury that's occurring over a period of time, it becomes chronically more painful and they're not able to do activity. Now, when we look at the knee, it's important to know the anatomy of the knee. That lets us know where the cartilage injury may be. If we start on the left side of the screen, you can see where it says patellofemoral. That is basically around the kneecap area. So if patients are swollen knee and they're sore in that area, that may mean to me that there's a cartilage injury in the kneecap. When we look at the knee on the right side of the screen, you can see where the arrows are pointing to the medial meniscus and the lateral meniscus. If they're tender over there, that might mean a meniscus injury, which is very different from a kneecap, a cartilage injury to their kneecap. So once again, it's important to know where they're sore, when their knee is swollen, or even when they're not swollen, to let you know where that injury may be in the cartilage. The most telling sign, as I mentioned, is when their knee is very, very swollen. So in the top right picture over there, you see the normal side. On the right side, you can see that knee is swollen. At the bottom, once again, you flip the images around, the right knee is very swollen and the left knee is not. So once again, that's a sign to me that the knee joint is upset because it's basically trying to lubricate itself. It can also mean that there's some blood inside there. So when a young kid who's between 7 and 12 presents with a swollen knee, I'm thinking most likely there's an ACL injury and possibly a meniscus tear as well too, as well as damage to the bone and cartilage because that knee has been injured and upset. In kids who are a little bit older and adults, usually it means that when their knee's swollen, they've had an ACL injury, a tear to their cartilage, meniscus cartilage, or to their articular cartilage. So once again, a swollen knee for me, particularly in a kid, definitely indicates to me that there's been some sort of cartilage injury that we need to be worried about. After we've gotten a good history on them, we basically will then check their motion. So once again, if a knee is very swollen, that can indicate to me that there's angry and their motion will be decreased. It can also mean that there's loose pieces of cartilage floating around that are blocking their range of motion. So if you have a swollen knee and you can't bend it, I get extremely concerned. A special test that we can do to see if the meniscus is actually torn, it's called the Macmurray's test, where you basically bend the knee up and rotate the shin bone back and forth. That basically will stress the meniscus, and if patients have pain with that, that can indicate to me that they may have a tear in that cartilage of their knee. We also want to test the ligaments, because if you don't want to basically try to fix cartilage if the ligaments are torn as well too, because the cartilage is going to keep getting torn up if you don't address the ligaments. So there's a test called the Lockman's test, where you basically try to move the shin bone forward, which can be indicated when there is an ACL tear. When you tear the ligament behind the ACL, the shin bone may move backward. That's called a PCL tear, and that's when you try to push the shin bone backwards. And then you've got tears of the ligaments on the inside and the outside. So you can have a tear to your MCL, which is how you test it on the right, or a tear to your LCL, which are the ligaments on the outside part of the knee. So once again, you're not only looking for where the cartilage injury is, but also looking for where the ligaments may be torn, because you need to address both of those things at the same time. After we've done a good physical exam, then we'll get x-rays to see if there's anything broken. X-rays are really good for breaks or dislocations. It's good to check alignment, because sometimes kids may have cartilage injuries when they've not actually had an event where someone hit their knee or they fell down, because of the way their knee is aligned. So if someone's very, very knock-kneed or bow-legged, that may put more stress on one side of the knee than the other, and where that cartilage, that's something we may need to address. It also looks for signs of arthritis. So if I see arthritis on an x-ray, that indicates to me that the cartilage has been injured. And we're also looking for weird things such as tumors, etc., that can also pop up on x-rays. But most of the time to diagnose a cartilage injury, you do need to get an MRI, which stands for magnetic resonance imaging. And that's basically looking for all the things in addition to the bone. So looking at the ligaments, looking at the tissues, and particularly looking at the cartilage. So when you look at that image on the right, you can see the thigh bone at the top and the shin bone at the bottom, and the kneecap kind of all being on the left side of the screen. The black, which is kind of outlining the bones at the end there, is the cartilage. So we're looking for disruptions in that cartilage. So an MRI is very good for looking at ligament tears. It's looking for tears of the tendon, which is basically where muscle attaches to bone. It's looking for cartilage, and it's looking for loose pieces of cartilage and bone floating around. So that's really key for us when a kid comes in with a swollen knee, to figure out where the cartilage injury is and what the treatment may be. So this is an example of an MRI. This is a kid who's got extra cartilage on the outside part of the knee, and you can see on the left, very left there's almost like a big black bow tie in between the thigh bone and the shin bone. That's the meniscus, and it's a little bit thicker than usual, and this is what that meniscus will look like during surgery. In the middle image, this is an image of a person who has a tear of their ACL, and that's what a torn ACL looks like on the arthroscopic image. And then once again, this is another picture of the meniscus. So you can see a little metal device right in the middle of a meniscus tear on the right image. So once again, things that we can see on MRI, we once again confirm if we need to during surgery. Now, what are some things we can do to make things better? Okay. The first thing we always like to do whenever anyone has a swollen knee is to rest, ice, compression, and elevation. The next thing we'll do is some physical therapy. Even if they're going to need surgery, we want to be able to get kids motion back. We want to make sure that they're comfortable and get their muscles strong. So a lot of times, even if they are going to have surgery, we'll get them into physical therapy and start some basic exercises to get their muscles strong, to get them ready to heal or get them ready for if they need surgery. Occasionally, if a cartilage injury is really bad, they'll need a brace, and there are various types of braces you can use in the early period. But we don't like to depend on braces too much, because if you're using a brace for a long period of time, you're not developing that muscle strength back. So braces are good when you're having difficulty with muscle strength and controlling your knee, or after surgery when you need to protect it for a while. But we really try to get rid of braces once the acute part of the cartilage injury has taken place. And then sometimes the injury may be so bad that we need to do surgery. And one of the ways we like to do cartilage surgery is with a camera called an arthroscope. And that's most frequently used in the knee. And that's a good technique both to, number one, treat injuries, or number two, to look a little bit further if you're not completely sure what may be going on with the knee. Now what we're going to turn to is kind of two examples of cartilage injuries that we see quite frequently in our pediatric patients. Okay. The first one is called an Ocd lesion, which stands for osteochondritis dissecans. Okay. Now I talked about this lesion a little bit. This is sometimes a condition that can develop even when kids don't have an injury, but it's the most frequent cartilage injury that we see in kids. If you see on the top right screen over there, that's a picture of Greg Oden. He doesn't play in the NBA anymore, but he had very bad OCD lesions in his knees and actually had to stop playing in the NBA and had to get several procedures. So it can be a devastating procedure, and we can see this in very, very young kids, and we'll talk about that being the most common cartilage injury we see in kids besides meniscus injuries, which I'll talk about in a little bit. Okay. So this is a case example of someone who has an OCD lesion. Okay. This is a 12-year-old male who came to my clinic who had very dull medial knee pain, which means on the inside part of the knee. It had been going on for 4 to 5 months. He didn't really remember any history of trauma. And I mentioned to you, sometimes these cartilage injuries will pop up over a period of time from repetitive wear and tear or just simply from something that the kids may have been born with. He hasn't been playing sports, but had similar symptoms in his other knee. Now, when I examine him in the clinic, he's very tender over the inside part of the knee. He has a little bit of swelling, okay, but not a large amount. When I really bend his knee up and rotate, he's really tender over the bone, and he doesn't have pain elsewhere. Okay, so you get this X-ray, and you're looking at this X-ray, and nothing looks really grossly out of place. But then you look over here, and you say, "Huh, it looks like there's a little area where there's a little bit of a hole. Maybe there's something right there, but we're not 100% sure. So let's get an MRI." And we get this MRI, and on this image over here, pop back over here, you can see on the left side of the screen, there's an area of white that's right kind of on the inside part of the knee, also on the right screen over there. So that's an area where the bone has been weakened and is an osteochondral lesion. Okay, we'll show you another example now. So this 16-year-old male who's had knee pain for 2 years. He plays football, and his knee swells up all the time while playing, particularly when he's hit. He simply is a very tough kid, so doesn't come into clinic, but he's tender over that same area. Once again, has some swelling and doesn't have pain elsewhere. And you can see on this X-ray, on the front X-ray, things look good, but then on the X-ray on the right, it almost seems like there's a chunk of his bone missing over there on the right side of the screen. Rather than being rounded, it's very, very almost like there's a piece missing. We then look at the MRI, and you can see on the MRI, there's a very kind of circumscribed gray area there on the right side of the screen. On the left side of the screen, on the right side, you can see there's almost a large piece of bone that's almost going to fall off. You see this little crater there. So once again, this is a very large OCD lesion where the cartilage of bone has been weakened, and he went on to have surgery. Okay. So what is it specifically? Like if you really try to define what an OCD is, it's basically when cartilage and the bone underneath it detach from the surface or are about to detach from the surface. Okay. This can happen from trauma or something that can develop over a period of time just by the way kids are born. And they're basically two groups. There are kids who are super young who are still growing who do very well with these injuries, or people who are done growing and they have a very poor prognosis. The reason why we get very concerned about this is that untreated can lead to very chronic pain and functional impairment and early arthritis. Now, it occurs pretty frequently. It's about 10 to 29 cases per 100,000 people. We see a lot of it in kids. It's 4 times higher in males. And most commonly, it's in the end of the thigh bone, but you can also get these in the elbow and the ankle as well, too. And some people have it on both sides. And these are the most common locations of the knee. Most of the time, it's located on the inside part of the knee, but you can also get them on the outside and under the kneecap. Okay? Generally, these patients may or may not have a history of trauma. And the reason why they may not have a history of an injury is a lot of times these lesions, although they may develop when someone gets hit or from playing a lot of sports, can develop just simply because during the time of development, patients will have less blood flow to that area, and they'll develop one of these cartilage injuries. And then they're playing sports, and because that cartilage injury is already there, and they're doing a high-impact activity, suddenly it will then aggravate the piece. Generally, they'll have vague and poorly localized knee pain. They'll have swelling and varying degrees of stiffness. Particularly when they twist and cut, it'll hurt them worse, and they may have locking or catching. So the image at the bottom left is an MRI picture which shows an OCD lesion there, and this is what it looks like during surgery. There's a big divot there and a piece that was floating loose. It should look white all over the end of the bone, but it actually looks, you see a bunch of reddish tissue, which indicates the cartilage has been damaged. So on an X-ray, you can see what it looks like there. On the left is a normal X-ray. On the right, you can see where there's a piece of bone which appears to be floating, which is not actually floating. It just means the cartilage is very strong around it. And then on an MRI, you can see it as well, too, and that's what it looks like. And what we're looking for when we're looking on an MRI is not only diagnosing that there's this cartilage injury there, but whether there's fluid behind it. Because if there's fluid behind it, that fluid has to come from somewhere. And the only way fluid can come there is if there's already a crack in the cartilage for allowing fluid to kind of leak behind it. So when I see fluid behind it, I get very concerned that piece may actually fall off. When we think about treatment, this is a very busy slide. There's a lot of different recommendations for treating these. It's still an evolving science. This is done by our National Academy. And you can see on the right here, they really didn't have many good recommendations for treating these because a lot of different people treat them in different ways. So once again, as we understand the biology more and we understand more about how these develop, we can develop better treatments for them. Now, how we determine treatment is based on the grading. So there are a lot of different grading systems. This is a system of grade 1 through 4, where basically your cartilage may be soft for a grade 1, and in grade 2 it's starting to fall off. Grade 3 it's about ready to fall off, and grade 4 when things are completely falling off. So once again, this is one way to grade it. Another way to grade it is basically by how it looks. There's a group called the ROC group, which just studies these. It's a multi-center group, and they define it based on what it looks like during surgery. It can look like a cue ball. It can look like there's a shadow. Or it can look like there's a wrinkle in the rug. And also for ones that are loose, it could be like a locked door, trapdoor where it opens up, or a completely exposed crater. So once again, there are various classifications for these lesions and various ways that we can treat them based on that. Now, if you look at these slides, there are multiple people who have developed various different treatment protocols for these lesions. It can be very complicated. This is one out of Children's Hospital of Philadelphia. This is another one out of Rush University in Chicago. But really the end comes down to is you basically look at how big it is, how severe the injury is, and then you can treat it based on that. So for some kids who are super young, you're saying the under 10 age group, sometimes we can try to just keep them off of it. And sometimes it can be from 3 months to 6 months of keeping them off of it, making sure they're still doing some physical therapy to keep themselves strong, but by keeping off of it, it can allow time for the body to basically heal these lesions in. But these are for these very young kids. If kids continue to have pain, but the piece is not actually falling out yet, you can do something called drilling, which basically means poking little holes behind the actual cartilage lesion. And what this actually does is allows this area to heal in. It's almost like creating little tiny areas of trauma, which causes more blood supply to come in. It's kind of like weightlifting, where you kind of create micro little tears in your muscles, and it gets stronger by doing that process. If we go in there, and you can get to these sometimes a little bit earlier, where the piece is just fallen off or is about to fall off, you can use dissolvable little darts to basically fix the piece of cartilage or bone back into place. So once again, that's the ideal thing we can do if we can catch these early. Another option is called microfracture, which you may hear a lot of professional athletes getting. And this is basically where the piece has fallen off and it's in multiple different pieces and you can't really put it back into place. So you want to basically try to get the bone to heal. The way you can get the bone to heal is by poking little holes inside the bone. And what happens is that new cartilage will grow out of this, from this bleeding bone, which is called fibrocartilage. Now, the important thing to note is that this fibrocartilage is not as healthy as the articular cartilage. So even though it does grow back in, it's not as good as your normal cartilage. So we really try to use this just for very small areas of cartilage defect. If the defects are much bigger, and we're saying 2 to 3 square centimeters, we can do a procedure called OATS. And what that stands for is Osteochondral Autograft Transport System. And what we're basically doing is if we find a large defect, we take little cartilage plugs, and you can see there on the right, these little holes, and we basically take the cartilage from one part of the knee that doesn't necessarily need it, and then placing it in a part of the knee that needs it. So you're basically stealing cartilage from one part of the knee to the other, but you have to use these sometimes for very big defects. If your defect is super large, then you may need to do something called an ACI procedure. And this is a procedure that's just been about 15, 20 years or so, and we're obviously getting good longer-term data. And it's basically a 2-step procedure where you basically go in, and if you see this big defect, what you'll do is biopsy some of the cartilage, you send it to a lab, it grows, and 6 weeks later, you can basically then inject it and then sew the cartilage back into the knee joint. Okay? So once again, it's a good potential procedure to have at your disposal, but it's for very, very big defects, and it does require 2 surgery. And then sometimes if your cartilage injury is so bad where you have basically a whole half of your thigh bone which has been damaged, or there just isn't enough cartilage cells growing after an injury, sometimes you have to take a piece of cadaver bone and basically place it in the knee where the normal bone is there. Luckily, we don't see this very often in kids, but just as kids continue to play more sports, I think we're going to see more and more of these injuries, where sometimes we'll need to put artificial bone in the areas because they've just torn up their knees so much. So this is a case example. This was a 12-year-old patient who came in, had an osteochondral lesion. You can see there's some white behind that area. And then we went during the surgery, and you can see when we're pushing on it, it didn't necessarily look all that bad. Those are the top 2 pictures there. But then when we actually went inside the knee, you can actually see on the bottom, this middle left image, there's actually a trap door where the piece of bone and the cartilage completely opens up. You can see those 2 middle images. So what we did during the surgery is we took some cartilage and bone and basically filled that area up and then basically placed it back into place. So once again, you can notice that this is an injury which, left untreated, could have left a big hole and defect in this young child's bone. Now moving on to number 2, we'll talk about meniscus tears. This is the second most common thing that we see in kids. Many people are very familiar with meniscus tears. We're starting to see them more frequently in adult patients. Excuse me, in pediatric patients. So this is a case example of someone who may have a meniscus tear. This 16-year-old male who comes in with right-sided medial joint line pain after a twist injury. He notes his knee is locked. He's very, very swollen. He can't extend his knee. And when we try to bend it back, it hurts a lot. And this is an MRI example that basically is looking at the knee, and you see a lot of white, which indicates swelling. Basically, when you look at this knee, you see a lot of black material in between the thigh bone and the shin bone, which once again indicates a meniscus tear. And that's something that we need to fix, because without the meniscus, you won't have good cushion in your knee. So what the meniscus actually does, it serves a different purpose than the cartilage on the end of the bone does, which we just talked about. And basically what it does, it shares and distributes load. And I like to use the truck tire analogy. If you basically lose one of the truck tires, what ends up happening, you have more stress on the rest of the truck because that tire is not working properly. And that's what the meniscus does. On the bottom left picture, you can see a good healthy meniscus that's there. It shares and distributes load. But then suddenly you get rid of the meniscus or the meniscus is damaged. As a result, you put more stress on the bone and other parts of the meniscus, and you get more cartilage wear. The meniscus also helps to stabilize the knee. So when the ACL is torn, the meniscus tries to stabilize the knee. Unfortunately, it's not very well designed for that. So when someone has an ACL tear, the cartilage, which is the meniscus, tries to help to make sure the knee's not moving around a lot. And as a result, that meniscus wears away as well too. So that's why it's important to recognize if there is a ligament injury at the time of the cartilage injury as well too. The things that you'll see on history and exam with these people, some people have a very acute injury where they come with a swollen knee, or sometimes they'll have chronic pain over a period of time. They'll sometimes have locking and catching, meaning their knee is getting stuck. It's associated a lot in kids with a ligament tear. It particularly hurts when you do deep squats, and usually hurts kind of at the back, inside or outside part of the knee. And this is what it looks like on MRI. You should usually see a nice and black structure between the thigh bone and the shin bone. When you see these large white lines, that indicates the meniscus is torn. And one of the things that they've noticed a lot is that a lot of times in kids, MRIs will basically show a lot of signal, which means a lot of white in the meniscus. And that's why it's important to know that sometimes the normal, healthy, developing meniscus will have increased signal, which means increased white. So really you have to look at is not necessarily looking just at the MRI, but looking how they examine. If there is a lot of signal on the meniscus on the inside, but they're having soreness on the outside, it may not mean that that meniscus is torn. So it's really important to take both the MRI and your history and exam all together when determining how you're going to treat these kids. Now, basically two treatment options. Number one, you can do surgery for meniscus tears, or sometimes you can let people keep playing. Now, what's the decision to let someone that needs to get fixed? These are usually tears that are acute, meaning that they happen because of one single event. Patients usually come in, they feel that their knees are locking, it's catching, they're in very severe pain, they're young. Ones that you'll usually let people keep playing, even if it's a very small tear, they're having occasional pain or they're a little bit older. But the vast majority of pediatric patients or our young patients under 18 who are athletes will generally need to get this fixed because they're stressing their knee that much more. Now, there are two things you can do when you have a meniscus tear. You can actually either shave out the portion that's torn, or you can repair it to basically preserve your own tissue. Now, what helps us make this decision, a lot of it has to do with the size of the tear, but more importantly, it's where the tear is located. And the blood supply for the meniscus comes in from the outside and decreases as you go more inside the knee. So you can see this overhead view of the meniscus. On the outside, those tears have very good blood supply and are going to heal very well, whereas the tears on the inside do not have any good blood supply at all. So what you don't want to do is repair a tear in an area where there's no blood supply, because that tear is not going to heal. You also don't want to take out a tear that's in this area that's very, very well perfused with good blood flow, because that will then lead to a lot of arthritis. So once again, if there's good blood supply in the meniscus, we try to repair it. Otherwise, we'll just shave out the portion that's torn because it's basically not doing any purpose. When we repair the meniscus, there are various ways we can do it. There are various devices, and basically what we do is stitch the meniscus back together, have patients stay off of it for about 6 weeks, and they can get back to their activity in about 4 to 5 months if they've healed very well. If a meniscus tear is located more on the inside where it doesn't have good blood supply or there are loose pieces floating around, then we go in and basically shave out the torn portion of the meniscus. Now, although this lets get people back to sports a lot quicker, sometimes as quick as 3 to 4 weeks, the problem is that once you take that meniscus out, it's not going to grow back. So you either want to, number one, not take out any meniscus tear, which is too large, because then they're not left with a lot of meniscus, or take out meniscus that you simply have to because it can't be repaired. So once again, although it's good to get back to sports quickly, it's not good to have less severe meniscus because that can lead to arthritis, which is shown in this picture over here. In the past, when patients had meniscus tears, they basically just took out the meniscus. They felt great for a while, then subsequently developed arthritis because there's no cushion there to basically help support their knee. One of the things we started doing in our particularly very young patients, if they had a traumatic injury, and it's not due to a generalized wear and tear, and the meniscus tissue can't be repaired or it just hasn't healed, is to do something called a meniscus transplant, where we basically will take meniscus, which is from a cadaver, place it in someone's knee to allow them to have some pain and be able to do some level of function. The important thing to note after this procedure, this is not a procedure that's done to get people back to playing sports. It's important just to get their knee back to normal so they can avoid getting a total knee replacement. Once again, something that we are starting to see in kids is they begin to damage their knees more frequently. So this is the case example we talked about before. It's a patient who had their meniscus floating around. You can see that on the top left image right over there. And basically what we did during the surgery is we sewed it back together and got the patient back to having a good functional knee. We didn't have to take any meniscus out. And as a result, it was almost like their meniscus was brand new, and they were able to get back to sports after an appropriate period of rehab. Now, one of the questions we get a lot is, can we grow cartilage? And that's really the kind of the next generation of cartilage engineering. And people always know, can we put cartilage, can we grow new cartilage out of just stem cells? There are techniques now, and I mentioned a little bit, called the ACI technique, where you do biopsy your own cartilage. This doesn't allow us to create cartilage out of cells which aren't cartilage. What we're doing is basically taking someone's own cartilage cells and having it multiply. Now, what this Macy technique is different from just a simple ACI technique is that we then take the cartilage that's been grown and basically place it on this little membrane, which is supposedly allows it to heal in a little bit better. So once again, this is a new technique that's beginning to be used more frequently, but we're still not at the point yet where we can take someone's blood, put it in a lab, and basically grow cartilage out of it in a predictable fashion. Something else that you may have heard of is called stem cells, or bone marrow aspirate, where we're basically taking the marrow, which is inside the bone, and using that to basically grow new cartilage cells. Once again, that can be used to help patients basically heal from an injury. So if they have a cartilage repair, sometimes you'll inject those into the knee to sometimes help what is already there to heal better or decrease inflammation. But once again, we really don't have a lot of data to support this yet. Once again, there's more things that can be known in the future. And once again, cell therapy, tissue engineering, taking basically stem cells and having it turn into cartilage. People are working on it right now. But once again, these are several years off before we can really just regrow cartilage and take someone who has arthritis and give them a new knee without using implants or metal in there. Excuse me. So to sum up, in terms of our top 10 issues for cartilage injuries in the young athlete, number one, pediatric sports specialization is rapidly increasing. This is leading to an increasing amount of adult pattern injuries, particularly cartilage. Cartilage provides support and framework for the body, so it's extremely important for helping everything work well and to keep us active. Cartilage does not like to heal, so that's why it's a very difficult injury to have. I'd much rather have someone come with a ligament injury that I can repair rather than have a cartilage injury, which is going to be very difficult to restore their normal cartilage back. In kids particularly, they'll develop cartilage injuries because they've had a ligament tear, they've dislocated their kneecap, or sometimes when they've had no injury at all and they'll develop that Ocd lesion we talked about. Fluid in the knee joint indicates to me that there may be a cartilage injury, so if an athlete comes in with a large swollen knee, that's something I'm looking for. As we talked about, one of the most common things that we see is this condition called an Ocd lesion, is where the piece of the cartilage and bone is injured. The treatment options for these, you can rest if you're really young. You can do a little drilling behind it if it's a relatively small lesion. You can fix it if you're lucky to catch it early. You can do something called a microfracture where you can poke holes in the little pothole and hopefully new cartilage will develop. You can take cartilage from another part of the knee and place it in the defect, or you can grow cartilage cells outside of the body, basically helping your own cartilage cells multiply. The meniscus is the other area where we see a lot of cartilage injuries in our young kids. The meniscus shares and distributes load. It helps to stabilize the knee, particularly when the ligaments are torn. And the treatment options for the meniscus are really repairing it versus shaving it out, and that really has to do based on the location that we have the injury. So once again, we're seeing a lot of these cartilage injuries in our young athletes. They're very serious. The best thing we can do is help our kids by having them play multiple sports, not do excessive sports activity, because the best predictor of outcome is them to never have a cartilage injury and never be in my office. But if unfortunately that does happen, we have a lot of techniques that are at our disposal to help us treat these injuries, and there's a lot of research and biologic frontiers that are being developed to help kids hopefully heal, as well as our adult patients as well too. Thank you. I'll now open it up to any questions that